So good evening, everyone. As we continue with our CMQ study group, this is a personally and individually, like voluntarily created group to study for the certification in medical quality. This is an initiative, as we said, started by myself and Rabab. And one of the updates from last time is that we were able to find a soft copy of the most updated edition of the certified the book that's actually in the certified medical quality recommended study material. So this is already sent in the group. We will share it again for the benefit of everyone who shared now, who joined now, and we'll continue to work on that. So as we promised, we'll be starting with some of the quizzes. These were thankfully created by Rawab, who helped me come up with those quizzes or questions. But I'll also use another slide that I had that has some of the questions from the CPHQ study materials as well. So for the first question, Codman has developed one of the earliest healthcare quality initiatives. Which one was it amongst those below? The end result theory, the SPO model, the 7 steps model, or the root cause analysis? 7 steps, end result theory, any more or less, any agreement or disagreements? Seven-step model, okay. Anyone else? Let me see. Mariam al-Mishjari, what do you think? Okay. I thought you were there. I'm sorry, I may be confusing you with the other Mariam. Let's then ask Mariam, who was volunteering to be our first victim. Mariam Smile? It is the end result theory. So Codman, remember, we talked about him being a surgeon. He was the one of the very earliest physicians to adopt a quality methodology. And he started by just looking at interventions that were given to patients and following those patients long enough to actually determine whether the intervention done by the physician was successful or not. And he said that every hospital or healthcare organization has to do that and determine the outcomes of or the end results of the care that they have provided to the patient. Was it really successful or not? So this is Amory Codman, Dr. Amory Codman, who was a surgeon, and he created the end result theory in the quality. So the point goes to, was it Sabita who answered correctly? Alicia, and we hope that's Sabita as well. Congratulations to both of you. Okay. The other question, and good to have you here, Anisha, with us. The other question was, which of the following is not considered a quality tool? The affinity model, the process mapping, Ishikawa, or the Six Sigma? Can someone read the question again? Excellent. So the Six Sigma is a quality methodology actually, which is uses most of these tools in it as while creating a Six Sigma. And we will talk more about Six Sigma today. So thank you for all of you who have answered. And you have to pay attention whether it's a CMQ exam, CBHQ, or whatever exam. They really focus on the terminologies and the use of things that which is not considered as or not something like. So really pay attention to those. terminologies and words. The third question is, one of the following quality improvement methodology is designed to be used in a small scale. So is it the BDSA, the Six Sigma, Lean, or the statistical control charts? Sorry. Come on, it's not that difficult of a question. Excellent. Yes. Yep. Yeah. So are you all Googling and trying to find answers, or what's happening? Excellent. So all of them are quality improvement methodologies. That's why this question might sound confusing, or at least three of them are. But when it say it's designed for a small scale, it's BDSA. Remember, we said it's used usually for pilots, for small scale improvement, plan, do, study, and act. And we will talk about it in more details today. Sure, go ahead. Mhm. Excellent. That's another way of looking at the answers when it's multiple choice questions. But actually, if you look from the beginning, when it says quality improvement methodology, immediately number four will be excluded because that's more of a data presentation technique or a tool. It was amongst the tool we studied last time. So then you look at the others and then you decide which of them is big scale or small scale. And BDSA specifically, when we said it's used to study for pilots for small scale improvements. And again, as we said, we'll talk about it again in more details. Okay, one of the following quality tools visualizes the relationship of possible contributors and variables to process. So one of the following quality tools to visualize the relationship of possible contributors and reliables and variables to process mapping, scatter diagram, fishbone, and histogram. So somebody already answered? Excellent. Possible contributors and variables to process. Okay. So the process mapping, you would look at a process and you would map that process exactly. We start with point one, so do this, then follow by this, and then follow it by this step, and you draw your process, your decision ideas or maps, and so on. Scatter diagram, again, it's another data representation diagram that shows you the relationship between data points. Histograms is more of a bar graph that shows you the frequency of a repetition of a certain data. Fishbone is the one that shows you the cause and effect relationship. So when we say possible contributors and variables, this is the causality or the cause and effect relationship between two things, and this would be the correct answer. Process mapping is only showing you the process and actually detailing the process elements for you. Please don't confuse everyone. That's all right. That's all right. I mean, somebody else might have already had the same answer, so it's always good to look at why did we not select the others and why not? Why did we only focus on one of them? That's true. You could think about it this way. Definitely. Definitely. So here we're looking at contributors. When we say contributors, it could be things that are outside your process that's contributing to the effect that you're having. So remember, we said in the fishbone, we look at the different, we could look at process, manpower, at maybe technique. So you look at all elements, including process elements that might have led to your outcome, right? So that's why we say the possible contributors and the valuable that ends. I think this is the last question. It says one of the following is related to Six Sigma. It has a series of its steps, has series of the BDSA steps, has a series of steps. The mic has an error-free percentage of 98.999 and used in Toyota production system. So which one of these is related to the Six Sigma? What about number 3? Excellent. So Rabab had done a good job making confusing all of you actually. So it is number 2. So the Six Sigma has the steps that the mic is one of its steps on implementing the Six Sigma. BDSA is related to the BDSA methodology. For number 3, it has a error-free percentage of 99.9996%. And then Toyota production system is actually the lean management. Thank you very much. This was all for the quiz. I would go into just very quickly going on the major points that we discussed in our last session. Just give me a minute. Okay, so this is session 1. Can you all see the screen? Okay. So again, we talked about the exam. You all have till end of this month to actually submit for the exam. And as we said, it's an online application that you submit for and you complete. And it takes a while for them to get back to you. So please make sure that you are submitting. And if you are planning to go for the CMQ exam in time, and then you would have to make sure that you pay before 10 November to be part of the exam. The actual exam takes place on the 26th of November 2022 in an university as a computer-based testing. Okay. Then we talked about the steps and the fees related to the exam application. We were actually using a different book last time, so this is the chapter listing as the previous book, and we will go today with the updated book chapters listing, as we will make sure that we always cross out the chapters that we have completed. The chapter 1 talks about the basics of quality improvement, so started with defining what is quality of care, quality improvement by AHRQ definitions, and that the recipients define care by whether it meets their own needs or expectations or not. We talked about the 3 aspects of quality. There is a measurable quality, appreciative quality, and perceptive quality. We said if we, for example, do a peer review of a medical record, so a physician practice is reviewed by another physician, which one of those aspects we are talking about? Anyone remembers? Appreciative, definitely. If we talk about the customer and how they perceive the care provided to them, so which one is it? The perceptive quality. And if we talk about the quality department going and doing an audit and having a checklist to measure quality standards and adherence to the standards, this is measurable quality. Okay. And then we talked about the history of healthcare quality. Dr. Ernest Amory Codman is the one, we said he created the end result theory. And about it, his whole idea was about following every patient long enough to determine whether the treatment has been successful or not. And if not, always ask yourself why not, in order to prevent similar failures from happening. This is what we call quality assurance or quality control. You just look at the outcomes of care and you measure it on a regular basis. Donna Bidian created an actual very important concept in the healthcare quality, which is the structure, process, and outcome paradigm. So these are important things that you look within in the quality healthcare. So who remembers what examples we gave about structure? What could be a structure? Resources, so the number of staff, supplies, equipment, policies, guidelines, staffing, okay, the environment that the people are working on. What about outcome of care? Mortality, morbidity, patient satisfaction, definitely. Okay, so all of the things that's measured as an outcome of the care we have provided, the mortality, readmissions we talked about, the care, the satisfaction with the care, and so on. What about, say that again, sorry? Nosocomial infections, definitely. So everything that we measure as an outcome of the care we provided, whether it's a positive or negative, it's considered an outcome measure. What about processes? What could we look for in the process? Workflows, definitely one of them. But what in the workflow? Hand hygiene, yes. So if you look at the rate of hand hygiene, this is one of the processes. If you look at how people are doing their hand hygiene, this is a process. If you look at the timeliness of the care, this is a process. If you look at reporting the errors, it depends how you're looking for it. Sometimes it's an outcome if you're actually looking, for example, at establishing an organization of culture of safety and so on. But process is everything that you do in between. If you're taking care of a patient, the way I clean the wound, the way I wash my hands, the explanation and the education I give to the patient, everything I do between, why we're actually delivering the care is a process. And looking at and measuring those processes is an element of the important element under the measurement of care. Then we talked about Walter Sheward, and he's the first one who established what we call quality control. And he was focusing on inspections and specifications and minimizing the variation in the processes to focus on the customer needs. He started talking about process control charts and so on. Edward Deming, and actually Sheward was the one who created or came up first with the concept of the BDSA. Edward Deming was a student of Sheward. Both of them started from a manufacturing concept, and he focused on something called the 14 points of care that extends also from the Donabedian model. And he focused more on things that were beyond the provider's or the person's care. So looking at things like the cultures, the values, the psychological climate, leadership involvement, openness of communications, and all of that as factors that influence quality. And then there were a group like Corsby, Deming, Joran, and all of those. When they continued working on their processes, they came up with the concept of total quality management, which looks at process control, involvement of the entire workforce, as well as creating a system design for improvement. In 1990s to 1990, in 1980 to 1990s, the regulators started being involved more in the quality of care, specifically in the healthcare, and accreditation bodies started showing up like the Joint Commission, National Quality Forum. And they started inspecting and assessing the quality of care and data across the nations. 1998, there was they started talking about the concepts or the problems of within the healthcare, which were overuse, underuse, and misuse. Anyone remembers what were the examples of overuse? Antibiotics, definitely. So you overuse antibiotics where it's not relevant. That's one of the diagnostic test was also an element that's overused, definitely. What about underuse? Lack of diagnostics test was one example we gave where a patient might be exhibiting some symptoms that requires a certain diagnostic test but not using it or not following it. And what about misuse? Misuse, as the word indicates, is using something for a purpose that it's not intended for. Misuse could be okay, definitely. So the using of resources where it doesn't belong was an example of misuse. And then in 2000, this is where it was like the biggest report in the healthcare quality came, which is the IOM, the Institute of Medicine, published a report called To Err is Human, Building a Safer Healthcare System. To Err is Human, this started to establish or to actually bring about the concept of errors in the human nature and how we have to create systems and processes that stops the errors from happening rather than blaming individuals later on. We talked about the different under misuse. There's also the complication we say that comes out of an appropriate service. Then we talked about the healthcare system design elements, and they talked about these 5 elements that healthcare should be safe when it's being designed, should be effective, should be patient-centered, should be timely, and should be equitable amongst all of the patients. We also talked about the different philosophies within the quality management. Accountability is an important part. Accountability in the use of clinical and physical resources, continuously develop and improve services provided to patients, and then clinical outcomes improvement as defined by the patients and the healthcare system. And then we talked about the different dimensions of quality. So anyone quickly remembers what's appropriateness? Come on, quick guys, we are only doing a review of the previous session. Appropriateness, what did we say about appropriateness? Excellent. So offering relevant, the treatment or the care that we provide or the service we provide shall be relevant to the individual's clinical needs. What about availability? Accessible and obtainable. Things are available, care is available, and patients can access it at all time. We gave example here of remote locations and patients' ability to access the care and so on. Competency. Mm, Competency focuses on the performance and adherence with the organizational status. So competency here, for example, we talk about the competency of the healthcare providers, how they provide the care to the patients, how we ensure that they are always able to do that. And that's why we have competency evaluation for nurses to make sure that they are able to deliver the BOCTs. We're always making sure that the physicians stay competent and that they do not do surgeries that they are not competent for, they are not privileged for, and so on. Continuity. Continuity talks about the coordination of healthcare needs over time. Who can give me an example on continuity? Maybe I'll, So go ahead. Hmm. Excellent. So things like the job of Mariam Ismail, of the case management, making sure the continuity of the care and treatment, the follow-up and so on is part of the continuity of care. There is also elements of continuity within the patient care in the hospital. So making sure the patient journey continues and it doesn't stop. So if the patient is in emergencies, goes to the unit, goes to ICU, goes back to surgery, there should be always that continuous flow of information and care for the patient, and that we're not always starting from scratch and dismissing everything that went on. Okay, effectiveness. What did we say about effectiveness? Quick, quick, quick. Who remembers? Effect. Okay, so it achieves the required outcome, definitely. What about efficacy? There's a word. Remember, we said there is a keyword. Literature. Yep. So effectiveness also can be in medication. It means it gave the effect. I took a Panadol, now I have less headache. It's effective. Efficacy, the research says that the tablet or 500, 1000 milligrams of Panadol for an adult makes sure that the pain goes away in less than an hour. So if that happens, if it's as per literature and so on, that means efficacy. What about efficiency, cost effectiveness, and the cost? And there's another word that relates to resources. Resources. So definitely. So not only cost, any resources that we use. So as we said, effectiveness is providing care that's correct and creates positive results. Efficacy is the capacity of treatment to produce the desired outcome as per the literature. Efficiency is the relationship between the outcome and the resources. The better outcome I get with less resources, the more efficient I would be. Prevention is making sure that we prevent diseases, respect and caring, always being sensitive to the individual need. Safety, making sure that we minimize the risk or the adverse outcome of them being in the hospitals. Timeliness is the most beneficial time or the perception of promptness. And when we talked about timeliness, we say timeliness does not always mean fast care or giving everything at once. It's also giving it at the right time and the right, as for example, if it's a medicine, it's given as prescribed every time and so on. And then we talked about the sources of QI, quality improvement. And I did not correct the type. Okay. So the sources of quality improvement. What did we say? What could be sources of identifying quality improvement opportunities? Anyone? Incident reports. Excellent. Risks. Excellent. Audits, KPIs, complaints. Definitely. What else? What is other sources? So these are sources that are usually showing as problematic, but there is also the innovations from within or the ideas of the healthcare, reviewing practices. There is things as looking at processes that are, remember we talked last time about high volume, high risk, problem prone processes, that all of these are things that I could look at that are sources of a quality improvement project. And then when choosing a quality improvement project, we talked about this grid, for example, of the impact and the urgency. Which ones would be the best for a quality improvement project? One, two, three, or four? One and one and two. So So anything that's a high impact, whether it's urgent or not urgent, is considered a priority, and you need to focus your resources and efforts and quality improvement projects on. The impact is important, especially if we talk about impact on the patient care, patient safety, patient satisfaction, and so on. The others, there are a lot of things that we do that are urgent, but if it's low impact and does not really impact the patient care or the patient journey, or not even urgent and low impact, it's maybe not worth spending effort in looking at those. So always, if you have 10 initiatives that you're thinking about, always look at those that are high impact and urgent. And impact is not only patient safety, it could be impact to regulatory requirements, it could be impact to staff capabilities and so on. So always the impact is depending on how you define it and what is important to the improvement projects you are establishing. Then we talked about the 7-step model for process improvement. It's always for any process improvement, and again, we will look at that. You would always identify potential targets for opportunity. You would always synthesize information about optimal practices, what could be the best way of doing it, and then look at your current practice. How am I doing it now? Identify the reasons for discrepancy between your current practice and your optimal practice. Then develop a strategy to improve your practice and to always go back to your optimal practice. Assess the effectiveness and cost effectiveness of the practice's improvement strategy, and then determine whether the practice improvement strategy should be implemented and how it can be improved. We talked about flowcharts or process maps, and it always has a start, a process, a decision point, an end point, and so on. And it has different shapes. It could be a basic diagram. It could be swim lane. This is what we call swim lane, which is that the activities are actually flowing from one department or from one function to another till it ends. Cause and effect diagram, fishbone diagram. This looks at the, as we said, the outcomes and all the different factors that could have impacted that outcome. Brainstorming and affinity diagram. Brainstorming, straightforward. You sit as a group, you start asking questions. There is no wrong or right answers, and then you start putting everything on sticky notes and so on. Affinity diagram is where you take all of those ideas that you brainstormed and you put it under certain categories. So what are those problems that affect, for example, our meeting, the timings, the focus, the attendees? You put all the relevant ideas under certain headings. This is what you call affinity diagrams. Pareto charts. Okay, let me see. What are the vital few? Adina, are you there? Can you tell me what are the vital few? Do you remember anything we said about the Pareto diagrams and the vital few? 80, okay, good. What does it mean to be 80? That's fine. Okay, so 80%. Anyone remembers and wants to participate? So 20% of what? I think you get it the other way around here. The 20%. Okay, so it's actually 20%. Anybody want to say something? Was it Anisha? Excellent. So the 20, excellent. So the 20% is actually the reasons or the factors that impact or that creates your problems. So you would have 20% of the reasons might be the create 80% of your problems. So let's think maybe this graph is not very clear. Let's say, for example, you are looking at the patient satisfaction, and you found that majority of the patients, so 60% of your patients are complaining about the waiting time. The other 15% are complaining about, for example, the what could we say, the cleanliness or the attitude of the staff. And another 5% of the reasons is the availability of, a coffee shop or whatever it is. And then there are other smaller reasons like the way the flow of the process, or I don't know, all of these things. So if you focus on these that make up 80% of the patients unhappy, which is these three reasons we said: the waiting time, the attitude. I forgot what was the third example I gave. So the three issues or causes that result in 80% of the dissatisfaction. If you solve these three, you know that your complaints or your satisfaction rate is going to improve and become 80% or above. Is it clear? So it's 20%. The vital few are those few reasons or issues that create 80% of your problems or quality problems or satisfaction issues and so on. Is it clearer now? So the vital few are not problems. The vital few are causes. The few causes that affect 80% of your problem or issue. The others, we don't ignore them. They still called the useful money. They are useful. If you solve them, you're still making patients happier, but it will not affect your scores as much as the first three factors, for example. So it is sometimes called 80-20. That is the major. If you hear Pareto chart, you always look at 80-20. Sometimes it is 70-30 and so on. Then these are some of the tools also, which is data representations, histograms. Histograms usually is different from bar graphs, that the base is very wide and connected to each other. This shows a range of data or information of the distribution of certain things. And then this is bar graph. A bar graph, as we said, the base is not connected. There is difference between them. So this is, for example, looking at the percent of length of stay. So this number of patients stayed less than 24 hours. This number of patients stayed between 24 to 48 hours. This number of patients stayed between 48 to 72 hours, and so on. So it represents data frequency across care. Statistical process control. Whom did we say amongst those historical people was the one who initiated the concept of statistical control? Sheward, definitely excellent. So Sheward focused on the idea that there is always an upper control limit and a lower control limit. If your data is within those control limits, then you are fine, you are meeting your quality targets and you're okay. If your data exceeds their quality limits, then you're having issues and problems. Again, when we talk about measurements in more details, we will be addressing even specific explanations of the different trend points and so on. And then we talked about methods for quality improvement very basically, and today we will start with that. That was the previous session. I just summarized it for as a refresher for all of us, and as well for all the new people that joined us today. Are there any questions on these? Okay. We'll go back to our today's presentation. We finished with the summary. If you look at the new book that we share today, the chapters numbering is different. So the first chapter we did and we discussed today is chapter 2. We will continue with chapter 2 and start with chapter 3 today, which is quality measurements. So basic quality improvement and quality measurements. And hopefully in the next sessions, we will be covering as many of those in preparations for the exam. Today's objectives, very optimistic, but we will be talking about methods and strategy for successful quality improvement in healthcare. We will list the key evidence-based quality improvement initiatives that affect patient outcome. We'll describe some of the evolution of science of quality measurement. We'll talk about characteristics of structure, process, and outcome, construct appropriate measurements for quality improvement, and then identify necessary characteristics for quality measures, including reliability and validity. The methods of quality improvement is specifically covered in this book. So what I'm trying to create those presentations to be in sync with the book. So when you're reviewing the chapters, you'll be able to connect with what we talked about today. So we'll talk about Plan, Do, Study, Act, Six Sigma, and then Lean Management. For the Plan, Do, Study, Act, first of all, it's as we said, it's used for small scale. This is the cycle for the Plan, Do, Study, Act. Plan, you usually state your objectives, make predictions, you develop a plan to carry out the cycle. And then in the do, you carry out the test or the intervention you said you will do, and you will document the problems and the unexpected observations that you will have. In the study, you will summarize what was learned, you will look at data trends, you will look whether every action you did has actually created the outcome you were looking for. And in the act, based on the outcomes here in the study, you will determine what's your next step. Do you need to continue the cycle and restart Plan, Do, Study, Act, or you need to close the cycle and then decide that maybe this pilot we did can be shared or can be extended to a bigger group. The BDSA is a trial and a learning methodology. It's based on a hypothesis or a suggested solution for improvement. And then it's tested on a small scale, as we said. And the purpose is to test and make sure that those improvements are actually working before I make organization or system-wide changes for quality improvement. Okay, who can tell me what are other names for the BDSA cycle? Deming cycle. Excellent. So can anyone tell me what's the difference between the Shewhart and the Deming cycle? There was very small difference. Excellent. So for Shewhart, it's Plan, Do, Study, Act. And for Deming, it was Plan, Do, Check, and Act. That's the only difference. And you can see it in both terms or both names, actually. As we said, Deming was a student of Shewhart, so he did use a lot of the tools and techniques. And Deming was actually the reason why many of those teachings were popular and became more popular and shared with bigger groups of people. You see here the BDSA, when we say the check, the BDSA usually goes on small cycles, and the purpose is that the data continues to improve. So the first hypothesis was tested, whether it was successful or not, we test another hypothesis to continue improving the data as we go. That's why we say it's really gradual and it is continuous cycles and processes. In this book, they talked about something called the Nolan's 3 questions in the plan stage, or in the plan stage. And this was for me actually the first time I heard about the Nolan's 3 questions. And these are the 3 questions. Very simple, very straightforward. You ask yourself questions like, what are we trying to accomplish? So before you put in a plan and you start creating 1,000 plans, what is actually the outcome that you want? What is the data that you want to improve? That's the first question. The second question is, how will we know whether a change is actually an improvement? Oh yeah, let's go change the policy. Okay, and then? How do we know it really improved the practice and the outcome? And the third question is, what changes can you make that will result in the improvement? And this is when you start putting your action plan into an effect. So let's say we have a problem with the patient satisfaction in the emergency department. So let me ask you these questions and you tell me, what are we trying to accomplish? Our problem is patient satisfaction in the emergency department. What are we trying to accomplish? Anyone can tell me? A patient should be seen before leaving. Okay. No waiting time. Okay. So appropriate. So you see what you did here. You assumed what are the problems that the patients are having. Who say they're having problems with waiting? Who say they're having problems with referrals? Who say they're having problems with being seen or not being seen before leaving? See, when you are in that place and you are asking yourself the question, what am I trying to achieve? My problem is patient satisfaction. So simply, I just want to make sure that my patients are more satisfied. Remember, we talked about the data trend that you are trying to increase or achieve. So patients are not satisfied. What I'm trying to do, I'm trying to make them more satisfied. Very simple. Okay, how will I know if whatever changes I make is actually improving what I'm looking for? Improving in numbers of what patients. Hold on. So improving in the number of patients, yes. Improving satisfaction scores, yes. Tools, what do you mean by tools? Okay, so remember, here I'm asking a simple question. How will I know the change I did is actually an improvement? So if I see the numbers increasing in the satisfaction, that means people are more satisfied. The scores are actually reflecting that data. Excellent. How do I know? I can see more patients are showing up to my emergency department. So this means the word of mouth going around my department is saying that, yes, this hospital is actually getting and delivering better services. Maybe we should be getting the care or the treatment there. Maybe. What else? Here you could start looking at more in-depth questions. So, sorry. Remember what you said about the patient's waiting time. Yep, you could start looking at data and then deciding that maybe after I looked at my satisfaction scores, I saw that the highest satisfaction rate was with waiting time. And now I'm going to look at waiting time as an improvement. Make it basic, up to the point. How would you know the changes you made are improvement? Sometimes what happens is that, for example, you would have an issue. For example, now, if we are trying to look at the patient satisfaction data, it takes forever to get the result because the result is done by DOH. DOH takes forever. They give you the data on a quarterly basis and all of that. So then maybe you need to look at a different way in which you can measure the improvement that your small BDSA are actually working. So what am I going to look at? What's the data? How will I know? And where can you use this question? Can anyone tell me where do you think in the BDSA cycle you can actually use this question or the answer to this question? You're asking the question in the planning, excellent. You will use it actually in the study phase. So remember, and we said the plan, you put plans, you implement your plans, study, here you're actually looking at your data. So whatever question you ask yourself here, you will put the baseline data for it and you will use it again when it comes to the study phase. Okay. The next, you will ask yourself, what changes can I make that will result in an improvement? So here you're actually now creating your plan in order to do it or to implement it later. Very nice three questions that really sets the base and makes you work with clear framework and clear expectations in mind when you're working on them. And the rest, as we said, do, implement, study, review. Act is how would you do, or what would you do in order to sustain the gain or continue to improve. Before I go off and move from the plan, do, study, act, I know it's very basic, it's everybody knows it, but sometimes looking at textbook and studying for exam or knowing the general information is different. Any questions here? I can't see if somebody is raising their hand, so please just speak up if you have any questions. Okay, hearing none. Thank you. The next quality improvement methodology here is the Six Sigma. And let me link it with the keyword, which is eliminate defects. The focus of the Six Sigma is to eliminate defects. If you remember one thing from the Six Sigma discussion today is that Six Sigma aims to reduce defect. Okay. The aim of Six Sigma is to reach a level of quality that resides in the sixth standard deviation of an average performance. Those of you who know me knows how much I hate statistics, and hearing something like this was gonna make me decide not to look at the Six Sigma ever again in my life. But let's try to make it easier. Six Sigma, they look at error rate, that's about 3.4 defects per million opportunities, or as we said in the quiz today, it's aiming for an improvement of or reaching to a 99.9996% compliance to whatever process we're trying to improve. The Six Sigma is a data-driven process. They use a lot of statistics, a lot of data. It's heavily used in the airline industry, in factories, and so on, because they really look at how they can improve and reduce defects in their products that they are making. And usually, this is how you would see a representation of a Six Sigma curve when looking at quality improvement. So here, this is the sigma. Okay, this is the symbol for a sigma. And it says that this is the data curve. When you look at any data, it curves starting going up to a certain point, which is the mean of the data, and this is the normal distribution of data. And then it starts to coming down to a less point. What it says is here is your mean. So if we're looking at if this was 100%, this would be the 0, this would be the 100, and this would be, let's say, the 50 maybe. And all of your data, again, as we said, if it's having a normal distribution, are gonna go through this curve. For a Six Sigma, for one sigma, which is one on either sides of the 0 of your mean result, is actually means the creation of 6,091,462 defects per million opportunity. And this is very important thing when we're talking about Six Sigma. Six Sigma is looking at million opportunities. So they look at things that are repetitive across the care episode. If you're talking about a factory, how many bottles do they produce? If we're talking about Coca-Cola, for example, how many bottles do they produce in a day? More than millions of bottles, juice bottles that they create. So whenever we talk about Six Sigma, they are looking at million opportunities, and then they look at defects per million opportunities. Are we clear till now? I can't see if somebody is doing thumbs up or something, so please tell me. So if this is, can anyone give me an example in healthcare? What could be happening as a million opportunity? Do you have anything that's actually happening in the million opportunities? Not length of stay, but surgeries. Yes. Or if we not focus on surgeries, only if we say procedures in general. then yes, we're having million procedures if you look at a quarter, or let's say, or maybe a year. What else? Something that's very common, whether you go to the emergency or you go to an inpatient or you go to an outpatient, something that happens. Diagnostic tests, definitely, specifically the laboratory diagnostic tests. These are huge. What else? Mariam al-Mashjari, something you work with. Vitals, true. Medications, definitely. Medications, how many opportunities? If you think one tablet per patient in a day, how many tablets the least patient would get in a hospital? Maybe twice a day. Think about how many patients we have, multiply them by the number of medications they have, multiply them by the number of times we administer the medications, and you will get million opportunities. What else? There was something very basic, like the first step when you go to a hospital. Registration. Registration happens so often that whether you go to emergency, outpatient, inpatient, you're always being registered. Can you imagine if we were at a 1 sigma of registration, we would be prone to have 600,000 mistakes or defects per million opportunity. That will be huge. Look at the finances. How many millions they deal with when they're talking about patient care. Imagine a mistake in the finance system or the finance calculation of some of those of our patients. If we are at a 2 sigma, 2 sigma is 2 from here and 2 from here. This is a 2 sigma, okay? This will be 69%, 69.1% defect free, which means 3,100 defects per million opportunity. Still, so much, a lot of defects per million opportunity. 3 sigma, we are 3 from here or 3 from here. What does it mean? That means 66,000 defects per million opportunity. But can you see by percentage what does it mean? 93.3%. So if Mariam is reporting medication administration compliance of 93%, what do we say? Oh yeah, good, mashallah, we are above 90. But what does it actually mean? Is that we have an opportunity to have 66,000 defects when it comes to medication administration. 4 sigma, we're moving up, where we're getting more data. So all the data between this 4 and this 4. And that's a very good number, 99.4, right? But actually there is still 6,000 opportunities for mistake per million opportunity. Again, think about all of those things we said: patient identification, medications, surgeries, interventions, finances, registrations, all of that is prone. Even if we are compliant 99.4%, we still have a chance to have 6,000 mistake per every million patients that we see. 5 sigma from here to here. I mean, this is excellent. 99.98% defect free. But actually that still means that we have 233 defect opportunities. We're dealing with lives. We're even dealing with something that's more precious than what factories deal with, which is patient's life. Any one mistake, any one defect in our system or processes could lead to a death, a permanent damage, a patient dissatisfaction forever. So that's why the aim here is to have a 6 sigma. If we have a 6 sigma, then we are reducing the number of defects to still, we are not making it zero, as close to zero as possible, which is 3.4 defects per million opportunities. Okay, or what we say, what we call the 99.9997% defect free. So do you understand now? The 6 sigma might look difficult, but actually it's only telling us that we imagine if every million patients you have, you're still hurting around 4 patients. It's still huge, it's still big, but it's better than 200 patients and 6,000 patients. And this is one thing that high reliability organizations and hospitals are working at, reducing and even reaching a higher sigma level than just the Six Sigma. Is this clear to all of you? Okay. So if we say 5 sigma, what's the percentage attached to it? Anyone remembers? 99.98. Sorry, 99.98. Excellent. Another thing, again, it was in the quiz today, which is the DMIC. We're still talking about Six Sigma, and Six Sigma actually, if you're studying Six Sigma and you're planning to have one of those belts, so anybody who studies Six Sigma can have a yellow belt, which is basic, green belt, which is intermediate, and then black belt, which is expert level, and then there is master black belt in Six Sigma. You would learn those practices. Six Sigma is not only used at solving issues or problems, it's also used to sometimes design, like if you're designing a new service or a new process in healthcare or in your organization, you could use a Six Sigma, but that's a bit different. It's called DMADIV, and it's all for designing new things. But we mainly use it as a quality improvement. So the model that goes with quality improvement is called DMAIC, DMAIC. And these are like each word is an acronym for something. So D is for define. What will you define? You will define your problems and objectives. So if you really look at it, this is the first question in the questions we talked about, the 3 questions we talked about. What am I trying to achieve and how? So what is my problem and what's my objective? My problem is patient satisfaction, dissatisfaction, and my objective is to increase or enhance their satisfaction. Then measure, M for measure. What do we need to improve? And here, remember, we will always link it to the problem that we have established. So in that case, it was improving the satisfaction scores, and then we looked at several sub-measures that we could look at. A is for analyze. Here you will start analyzing your process and analyzing the data that you have, and then you will look at factors that influence your process. So when we say Six Sigma is a methodology, when you're defining, you could be using some certain analysis tools or techniques. You could be studying your some data as a basic. When you're doing the measure, you will look at how you will measure, what graphs you will use. Is it a bar graph? Is it a bar chart or a pie chart, and all of those things. When you are analyzing, you could be using the fishbone, you could be using brainstorming, you could be using affinity diagrams. So here you see the interconnection between the tools we talked about and the models here. So you would analyze processes and you will identify factors that influence all of your processes. And then improve, it's actually linked to the implementing improvement ideas or methodologies. And then control is that you will ensure always that your improvement will be sustainable and it's continued and carried out through the process. Can anyone tell me, if we are comparing the mic with the BDSA, how will it compare? So for example, the plan from BDSA, where will it fit? Anyone can connect the two? D, define the budget. Okay. And analyze as well. Remember, I've linked the define, measure, and analyze with the 3 questions we've listed, because in the BDSA plan, you are actually creating your plan for improvement. You are analyzing, you are understanding, you are asking yourself all of those questions, you're coming up with improvement processes. And then the do is linked with here, the improve. Here you are actually implementing the plan that you said and you're implementing your improvement, correct? The S in study in BDSA links to which one here? S, study. It could be part, it's linked with measure and control. So here control is that you assure that your improvement will be sustainable. That means you're actually reviewing or checking the improvement. Did it happen or did it not? What about the A, act? Maybe not at all linked here. Act. So remember, we said act is you act to either sustain the improvement or then you start creating new plans. So it's also linked to the control. So here, when we talk about demand, you will assure that the improvement happened. So this is your studying, your analysis of the data after you implemented your improvement, and you're making sure that you're achieving the score that that you want, and then you will set certain measures to make sure that the process is controlled, is within the upper and the lower control limits that we talked about, and that you are having you are sustaining your improvement. If you are not sustaining it, then you need to go back and start the demic cycle again. And sometimes this is actually drawn as a cycle. So it is similar to the BDSA in that regard. Any question? Sure. Definitely. Definitely. So remember, we said BDSA is used in a smaller scale. So actually, when you are improving, it's very common that they say we've implemented several BDSAs within the improve phase as smaller improvement cycles. So I analyzed, I found patients are not satisfied because of waiting time. So I'm doing a lot of improvement methodologies or hypotheses to reduce waiting time. I analyzed and I found that the patients are not satisfied with the attitude of the staff. So within the improve, I'm implementing multiple cycles of BDSAs of how I can improve the attitude. And then I will review on a smaller scale whether it's improving or not. That's very good. Thank you, Hania. As we said, BDSA is used mainly as a small scale, but sometimes BDSA itself can be used as a quality improvement method in its own standalone that can be covering a full technique. The Six Sigma is very wide. It uses a lot of measurements, a lot of tools, a lot of other quality improvement methodologies within it. The concept is it all still falls within this organized process of the DMIC that we have. Thank you, Hania. And as we said, this is not only me lecturing you guys. I know most of you are experts. You already know this. Please go ahead and participate. Give your ideas or suggestions. If I have missed something or you have information that can benefit everyone, please do so. So when we talked about Six Sigma, what we said is the focus for Six Sigma. Eliminate defects or reduce defects, definitely. What about lean? Lean is focusing on something called waste. So lean methodology focuses on removing wastes, and lean is a Japanese concept. So they use a lot of Japanese words in it. Waste, it's sometimes referred to as muda. So removing muda or removing waste. This was initially established in the Toyota production system. It was, again, as we said, came up from the manufacturing system, where they started looking at their processes, identifying what could be wastes, and then improving it. Another terminology that's Japanese that's also linked to the concept of lean is the word kaizen. We hear it, and even sometimes it's used as a day-to-day language. Oh, today we'll be implementing a Kaizen, or this is a Kaizen project. When we talk about Kaizen, this is continuous improvement. It's something that happens all the time. It's continuous. We're improving, improving, improving. It's rapid, relatively low cost, simple, and team-based. And for example, for those of you who work on in SSMC, there's something called daily team system, and they use the Kaizen approach to identify problems. Or we're having an issue with ability to discharge patients on time nowadays. The team in the unit itself come up with ideas of how they can improve this and what they can do in order to achieve the required target. So this is what we call by Kaizen. Even if always, if you hear Kaizen, remember continuous improvement, team-based. It's usually at the place of work. And then Lean really looks at what we call non-value added processes, and we will talk about it more in a few minutes. Sorry. Lean, Six Sigma, BDSA, they focus a lot on customer needs as the center of their attentions, because all quality improvements you're doing are to address the customer needs. You identify what's the value for the customer, you map the value stream, you create the flow, the best flow, establish a pull system of responding to the patient requirement, and then you implement continuous improvement at all the time. And again, as we go, like any other quality improvement project, it's a continuous circle that you could always continue repeating till you achieve, because the customer needs are not stagnant. They always improve. They always expect more and more and more from you as an organization, and you have to continuously improve and achieve more for them. Okay, so what's Kaizen? Anyone can tell me what's Kaizen? Continuous improvement. It's team-based, it's small in scale, and it's usually low cost. Okay. What's Muda? Waste. Muda is the Japanese word for waste. Also, when we're talking about the lean concept, here we're talking about the different types of waste. So all of these are Muda. All the type of waste that are addressed when you're looking or talking about the lean concept. So let's now think about healthcare and think of what could be defects in healthcare. Can anybody give me an example about defects in healthcare? No. Waiting time is actually here under waiting. Waiting is a waste. Say that again. So defected, definitely defected supplies or equipment, definitely. So this is motion. So remember, I want to go one by one through the motion is here. Motion is an activity or it's a waste on its own, and this includes everything: transferring patients, moving from one room to another. Even when they look at assignments of nurses in the unit, the aim is to always reduce the waste and reduce the motion from one place to another. When you're looking at storage practices in the units or in the main stores, reducing motion is one of the activities. When you're looking at the OR rooms, the way you set up your equipment, so there is no excessive motions or going from one place to another to get the equipment, is type of the ways that we improve the motion as a waste in healthcare. But my question was initially about defects. We talked about defects in equipments and in supplies. Yes, remember at one point we had a certain cannula, IV cannula that used to break before we even inserted for the patients. This is a defect. The nurse will have to leave it, go get another one and start using it and so on. And sometimes it breaks when it's in the patient and then it results in issues and side effects for the patients. Other defects is all the defects that comes out from the care or from the things like wrong registration, adverse event, definitely. Adverse event, wrong registrations of patients is a defect that could lead to consequences for the patients, for the hospital. If you are cross-matching a patient blood type and then you have an error while doing that, this is a defect. So all of the mistakes, incidents that happens is part of the defect that we should try to reduce when dealing with patients. It's a waste because it will result in rework in order to try to fix that defect, which will consume more time. Overproduction in factories, this is very clear. Overproduction means that they will produce a lot of things that they might not need. What could be an overproduction in healthcare? Overuse of diagnostics or over prescribing of diagnostic through to start medications is overproduction. Consumables, overuse of consumables and overproduction. Sometimes you need only one cause to do something, and then you bring in a huge set of things, and then you start wasting them. This is overproduction. High length of stay could be an overproduction for healthcare. Yes, the patients are staying, resulting in us providing care that they might have not needed and could have been diverted to other patients that were in more need. Yes. And then we talked about waiting to be registered, waiting for diagnostic tests, waiting for food, waiting for resources, waiting for the rounds, waiting. Anything that involves a waiting is considered a waste. It doesn't add value to anyone. It just uses your time. Non-utilization of talent is also a waste. Can anybody think of example in healthcare of non-utilization of talent? Excellent, excellent. Not referring the patients to the right disciplines. This is a non-utilization of talent. What else? Talent. So employee talent could be, for example, that the patient might be in the wrong care area. They might be needing ICU care and they are in the unit. They might be needing pediatric care and they are in an adult area. They might be needing a certain procedure, yet we are not offering or we're not referring the patient to that procedure or to that service. Anything that relates with talent, and talent mainly is linked to, as Anisha said, the human resources and the people talent and capabilities. Not getting in the right team or the right resources to actually be part of the patient care or the patient rounds. Now, one of the ways we started utilizing talents, for example, is the multidisciplinary team meetings that we're having in the unit. So we would have all the right people available and involved in the patient care. Before, sometimes it's only one physician who's making decisions and they're not involving the rehabilitation team, the dietitians, the case management, and other team members in the care of patients. Okay, what about transportation? And see, there are two things. There is transportation and there is motion. So it's two different activities. So what could be transportation waste in healthcare? Anyone? Doesn't this remind you of something? The distance between services? Yes. Say that again, sorry. Transferring the patient from one unit to another? Okay, so that if the patient, sorry, if the patient is in transported within the wrong care, that's a defect. So we made a wrong decision to move a patient somewhere where they're not. And what will happen? It will result to rework because after a few hours you will have to transfer the patient back to ICU because they are deteriorating. But we were talking about transportation, as we say, is transporting patient from one location to another. The ambulance, for example, the use of the ambulances, the need to transport patients and to use other transportation means could be it doesn't mean to be bad or good. The only thing is that it's non-value adding, and it's wasting time that you have to actually take the patient all the way, for example, to SKMC or to Cleveland to receive the care where the service might could have been available in our organization. So transportation is one of the wastes. Inventory, the patient journey includes a lot of different types of waste. It could include transportation, it could include waiting, it could include defects, it could include overproduction, it could include motion. There's a lot of items or elements that are under the patient journey. So inventory, what could be an inventory waste? Expiry, yes. Having a lot of medications in the unit where you have to go review their expiries and count and recount. What else? Consumables, the availability in the consumables, a lot of consumables that maybe you don't need. And then also you need to count and review. What else? Okay. So that, but here we're talking about inventory. That's maybe um, what you call it? That may be related to something to any another type of waste. If we're talking about that, so inventory is a storage. Anything that related to storage and availability and keeping of additional equipment that you or resources that you might not need within the unit. Overstocking in general, yes. Anything that relates to it could be medications, could be consumables, could be patient care items, could be equipments, whatever that is, because it will create a work that results in that you have always to go back, you have always to count, you have always to look at the inventory and to count, to review them, which creates more work that may be not needed. And then motion, we talked about motion, anything that requires movement, not only in transportation, but as we said, remember, for example, sometimes you would find people who would do a procedure and they will move between different drawers actually to get certain items. So putting things or grouping things into one group where you could find all the relevant information, all the relevant resources to you. We talked about the OR, setting the case cards, and setting the items in a way that would reduce motion and reduce people movement from one place to another. If we talk about the patient journey, asking the patient to move from here registration to the doctor, go back outside to actually get your diagnosis, and then come back to the registration to get your appointment, and then go back to the registration to pay your bill, and then anything that creates all of those motions and all of those points of going back and forth is a motion waste. Extra processing, yes, that's clustering. That is exactly when we talk about the nursing. Excellent point. The nursing assignment, having a patient in the beginning, especially now in SSMC, having a patient in room number 1, and then having a patient in room number 15, and then having a patient in room number 23, and another patient in room number 30. So all of those motion is actually waste for the care of patients. Extra processing. What's extra processing? Who can think of something related to extra processing? Unnecessary data collection definitely is part of it. What else? Yep. What else? In case if you have to to admit a patient, what are the steps that we have to take? Or let's say a patient is in the emergency, they need to be admitted. So the emergency doctor will refer to the unit doctor. The unit doctor will see the patient and they will refer for additional blood test. Additional blood test will come and then it will go back to the emergency doctor. The emergency doctor will call the unit doctor and will inform them about the result. The unit doctor is then going to create an admission order document. That admission order document goes to the clerk in the emergency and then they transfer it back to the admission registration clerk and then it comes back to the admission is done and now it goes back to the nurses in the unit. The nurse has to call the nurse from emergency, the nurse in the unit, to make sure there is a bed available. The nurse in the unit checks and then comes back to the nurse in the emergency and tells her whether bed is available. So, and then they need to go back to the nursing supervisor. So imagine there are 20 steps just for one admission of the person, of a patient. That is extra processing. A lot of these steps could have been cut and removed for the process to become leaner for patient care. We have sometimes patients that are coming, they see the endocrinologist, and then they go out, they have to do a certain blood test, and then they have to wait for 3 hours, and then they go back and then go back to see the endocrinologist, and then they prescribe medications, and then they have to go back to the pharmacy to get the medicines, and then they have to go back to the lab to do other tests that are meant to be reviewed in the next admit. So whenever you have a lot of processes and a lot of steps that's not needed, that's called extra processing. And again, waste. Definitely. This is for the staff. If you have to get multiple screens, multiple areas, you have to go to the patient medication list, and then you have to go to another screen, and then you have all of that. Anything that requires you to do 1,000 steps where it might be easy from point A to point B, that's called an extra processing. So always go back and review. There is something called the 5S technique, for example, for environmental readiness, and one of the lean methodologies in the environment. And it aims to reduce any of those things that could be environmentally or process-based that are related to the staff and how they work. So when we talk about lean as a process improvement methodology, you could see that before the blue points refer to weighting and other non-value added items, or MUDA, or waste, in the patient care process. And the green bars are actually anything that's adding value to the patient. So let's see. The patient came, they want to see the doctor, they want to do the blood test, they want to get the education, and they want to get their medication from the pharmacy and finish. All of these blue points are all the weights or the non-value added items that are in the patient journey, and that's why the patient journey extends this long. When we use lean as a process improvement methodology, the aim is we cannot always remove the weight, you cannot always remove the waste, but the aim is to reduce these to the very minimum amount that the journey or the variances between all those things that add values to the patient are really very less and reduces the patient journey by half or more. Okay, and it says that the patient receives the same value because they still have all of those green bars, but with less time and resources. And when we talk about business improvement, sometimes they combine the Six Sigma, what's called Lean Six Sigma, and they focus on two things: eliminating defects in the process, and at the same time eliminating waste in and around the processes to achieve the best quality outcome for the patient. There's also something called the value stream maps. It's used very commonly in the lean methodology. And let's give you an example here of a patient in the emergency department. The patient goes to the emergency department, they register. So here, it's when you do a value stream mapping, you're actually counting what's called the cycle time. So the cycle time, the total cycle time here for registration is 15 minutes. The value added cycle time is only 5 minutes, which is the actual time when you are sitting there with the registration staff who's asking you questions and documenting them. The non-value adding is 10 minutes for the registration. But this is where the staff is inputting the information and clicking in the computer and all of that. So you could see there's a total 15 minutes, 5 of them is value adding. Triage, it's a 30 minutes process. Value adding is 15 minutes. The time it takes for the nurse to talk to the patient and ask him questions is only 15 minutes. The other non-value adding is another 15 minutes. So out of the 30, there's only 15 that is value adding. Treatment, the cycle time, the total cycle time is 45 minutes. Here, 35 were actually value adding, where the doctor was doing the assessment and the nurse was administering the treatment required and so on. And the non-value adding time was 10 minutes. And then there is a discharge process. And within the discharge process, again, the cycle time was 60 minutes, 45 minutes were actually value adding, and 15 minutes were not value adding. And in between those processes, you can see all of the weight items here. What they do in the lean, in the value stream mapping, is that they count all the value adding cycle times and all the non-value adding cycle times, and they focus on those elements to be reduced. They don't touch the value adding times. They only address things that are considered waste or muda, as we say, in the care, non-value adding points in the care of the patient. And the aim, as we said, is to reduce it and not to totally remove it. We talked about this table last time, which is the comparison of the 3 improvement methodology, plan, BDSA, Six Sigma, and Lean. I'm not going to go through it again, but very quickly, this is rapid cycles for improvement. Target project is chosen for improvement with limited time or resources. It's used mainly, or support tools is testing environment, prototyping, piloting of ideas, and so on. Six Sigma, this use the DMAIC principle. They eliminate defects and they are customer centric. The target project is chosen for improvement and resources are available. The project consists of an activity that's repeated with high frequency, as we said, the million opportunities, remember. They use a lot of tools like statistical process control, charts, analytics tools, Six Sigma experts, black belts, green belts, and so on. For Lean, they eliminate non-value added steps and eliminate defects and reduce cycle time, reduce the waste. They enhance efficiency, eliminating of non-value adding elements, and improve the flow. They focus here on the process efficiencies. They use things like value stream mapping, value analysis, and then Kaizen. This table summarizes everything we said about all of the different tools. Commonly used quality improvement strategies. Now, this chapter at the end talks about, in order to implement quality improvement, what are the common used strategies? Now, here we're not talking about tools and techniques, we're actually talking about more of how do we implement those quality improvements. When we talk about academic detailing, here we're talking about the things like when you go and have to face-to-face or one-to-one interactions with the clinicians to teach them or to tell them about the specific quality improvement and improvement in actions that's needed. So, for example, when we do education or we do an audit and then on-time educations, or we go to the units and we start explaining to them about the importance of incident reporting, the importance of quality improvement, why should we be doing processes the way we do it, and so on. That's called academic detailing. Opinion leaders. Anybody can guess what do we mean by opinion leaders as a quality improvement strategy? Did I lose you all? Did you all go to sleep already? Opinion leaders, feedback? No, not quite. It's closer to peers feedback. Opinion leaders here is talking about the use of people that are popular in the organization, that they are not leaders as such, they are not the managers or the directors in the department, but they are people that influence other people actually and make them they could listen to them. So opinion leaders usually, if they um, believe in a certain improvement idea, they could sell it to others, they could share it with them, and it's very common that they are used for the quality improvement practices. Audit and feedback, very straightforward. You do an audit, you identify consequences, and here actually it's not only talking about when we are dealing with clinicians, it's also talking about improving quality for patient care. So when you see patients, you collect data. Let's say you look at the diabetic patients, you collect data on their compliance to their medications or treatments, and then you provide them feedback about that and how they could do better, and share with them data of similar researches and so on that could improve their compliances. Reminder system. This is something like the medication. Sometimes when you're ordering something, it tells you there is an interaction between medications. It tells you the patient weight is needed for this type of intervention and so on. So these are commonly used in healthcare now, and the electronic healthcare record, where a reminder pops up to alert you to a certain important tool. Sometimes it's overused. There's an overproduction of reminder systems, but it's also one of the proven quality improvement strategies in healthcare. Patient education, a very strong tool, specifically when we're talking about patient and patient compliance to medication and treatment. Making sure that you understand the patient needs, you analyze it, and you educate the patients accordingly is very important. Case management. Case management, here we mean managing the patient case from beginning to end and addressing all the deficiencies and the variances that's happening in their care is part of the quality improvement strategies that's used. Re-engineering focuses on looking at the processes, improving it, re-engineering it, and changing the way it's done. So when we talk about re-engineering, we're actually not following the same workflow we always have. We're trying to come up with the new or novel ideas. And this is one of the ways that usually innovation happens in healthcare. Incentive, as we know, is just offering incentive. It doesn't have to be always financial, but any way of encouraging the people to actually adopt the good practices to improve their care and so on. Okay, here, this is, I think, the last part in chapter 1. It talks about challenges to successful quality improvement. So technology, anyone can tell me how technology can be a challenge to quality improvement? Too many others. Yeah. Updates, requiring updates. Sometimes it's the availability, the confidentiality, the availability of the right technology to actually be able to administer or to perform the quality improvement that you want is also one of the ways that you could look at. Structure. What could be structural issues that could be a challenge to successful quality improvement? Staffing, availability of the resources, policies, guidelines. So a lot of structural things that we could uh, actually look at and address when we are trying to improve the quality of care. Psychological climate, what could it be? The work environment, the quality of care, the culture in the organizations, the teamwork. Do we have teamwork or not? Do we have a lot of barriers and boundaries amongst us as staff or not? All of these are part of the psychological climate. Leadership. How can leadership be a challenge? Lack of support, definitely. What else? Lack of communication. If people do not believe that the quality is important to the leadership team, many of them will just continue doing what they're doing because what's in it for them? So leadership involvement, support, visibility is some of those elements. uh, Definitely, leadership. This is very good point. Leadership styles. If you, for quality improvement, you could mainly require somebody who is having democratic leadership skills, somebody who's participatory, definitely participatory, listening to the staff front lines, getting their ideas and helping them be part of it. All of that is definitely part of leadership. And if they are bureaucratic and not allowing for participation and involvement, then you would definitely not have a part improvement. Culture. How can a culture be part of a challenge to quality improvement? Sorry. What do we mean by culture? Definitely not being a just culture. If it's a blame organization where people are being blamed for making mistakes, then everyone is going to try to hide mistakes and never speak about it. Definitely. If there is no culture of accountability, resistance, transparency of information, if it's a culture that's not data driven, so we're only depending on our hunch or our guess to create quality improvement, then definitely that will be a challenge to the way we do quality improvement. Legal issues, what could be? Licensing issues, approval, what else? Accreditation is part of it, definitely. But here we're talking mainly about legal implications. So imagine someone talking about Sentinel events and culture of safety, and we had 3 Sentinel events in our hospital this year, and it was because of this, and this, and then somebody takes it and makes it a legal issue and raise it to court and starts suing the organization about it. This is also one element of legal issues. Also, the support required if you're implementing a quality improvement initiatives that requires certain things that might impact the legality of how you deal with the patients. Then you need to involve the right people, the right legal authorities to make sure that the quality improvement is not going to result in you um, uh, getting more accusations and issues. These are 4 challenges in healthcare. I was planning to start with chapter 3, and I think it's very basic 2 concepts, but we only have 2 minutes, so I will stop here. Chapter 3 focuses on the quality measurement and data, so we will address this in our session next week. And before I stop, I want to know from all of you, do you have any questions? What's your feedback on this session, and what could we do better for the next session? You are very Thank you very much. Please do one thing. Read the chapters. It's really, when you look at it, it's very it's very easy to read. It's like when I put it in the slides, it might sound so much, and I'm trying to give examples to connect all of this back to the way we do business, to healthcare, and so on. But when you read the chapters, you feel summarized. It will help you keep the idea. The exam, for all of you who are planning to take this exam, is very close by. We basically finish the last session, and then the week after that might be the exam. So please make sure that within this week you are able to go back, you are able to read. We've sent you the book. You can even download it in your computer, and you could study. These 2 sessions were basically only talking about chapter 1. the basics of quality improvement. They call it the basics of quality improvement. And it's really very important that all of you spend the time and effort to read. No matter how much I try to share the information, you wouldn't get the best result unless you're really taking the time to study or to read the book as you go forward. What about the base of the sessions? I know when we were doing the review, I tried to go fast. So it was mainly a review of last session, and I focused on most of the key points in our discussion. But I tried to also be on a medium base all through the session. So was the base okay? Thank you. So I can only hear Adina and then one thumbs up. I think I lost the rest of you. Oh, thank you for those and all the best in your exam, inshallah. Yeah, yeah, I know that's the quiz was from Rabab, and I think maybe if not next session, the session after is gonna be mainly Rabab's preparation, if not presentation. So thank you very much. I don't want to take much of your time. It's already 10 p.m. on a weekend. So uh, please enjoy the rest of the weekend, and I will see you next week, inshallah. Thank you all. Bye. Good night.